Good evening, everyone. We'll get started in a moment here. Welcome. What a respectful crowd. Hello, welcome. Good evening. My name is Sasha Nadeau. Bonsoir. I am the Director of Programs and Services at the Alzheimer Society of Nova Scotia. As you may know, January is Alzheimer's Awareness Month, and each year we aim to get Nova Scotians talking about dementia. This year, we did so through a campaign about reducing your risk through 10 actions. Based on the latest research, we now understand that 40% of risk is changeable through lifestyle factors. This is one of the many current research concepts we will be discussing this evening. It is my sincere pleasure to welcome you to our event, Hype versus Hope in Dementia Research. First, we'd like to acknowledge that we are in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq Nation. We are all treaty people. The Alzheimer Society is committed to creating collaborative and respectful relationships. Together, our goal is to identify and develop tools that align with the beliefs and needs of Indigenous, African Nova Scotian, Acadian, and all equity-deserving groups across our province. We are committed to walk as community partners and allies in the elimination of racism and discrimination. This past year, the Alzheimer Society of Nova Scotia recognized its 40th anniversary. That means 4 decades of providing information, education, and support to all Nova Scotians on the dementia journey. This evening, we are hosting a hybrid event, and I'm pleased to share we have nearly 500 people registered, so a large virtual audience this evening. I'm also pleased to share this event will have an even broader reach, and the video will be available for sharing and viewing again after the evening. Whether you are virtual or in the room with us here, thank you for joining us. And to our virtual audience, if at any point you're having trouble, our virtual support staff are happy to help. A few housekeeping details for those in the room. The washrooms are just out the back of the hall to the right up here. And as we know, COVID-19 is not fully in our rearview mirror, so we ask you to take steps to reduce your risk as you see fit, and we thank you for respecting the choices of fellow attendees and helping us have a successful, safe event. Thank you to Basil Audiovisual, our producer for this evening, and the Halifax Central Library for hosting us. Speaking of which, please take a moment to put your phones on silent. I'll also invite you to connect to the library Wi-Fi. This will come in handy during our Q&A period. Before we dive into the discussion around areas of hype and hope in dementia research, we thought it'd be wise to get on the same page about what research is and what research isn't. We've prepared a mini presentation thanks to our colleagues at the Alzheimer Society of British Columbia to share some research concepts you might hear about regularly in news reports. In the age of information, we thought it'd be valuable to get some tips and tricks on how to ensure your sources of information about research are reputable and sound. This backdrop will be presented by this evening's expert and moderator, Dr. Melissa Andrew. Dr. Andrew is a staff geriatrician and professor of geriatric medicine at Dalhousie University. Her research interests relate to frailty, social vulnerability, vaccinology, and cognitive impairment. She chairs our research advisory committee, many of whom are panelists this evening, and has been on our Alzheimer Society Nova Scotia Board of Directors since 2013. Welcome, Melissa.
Excellent. You don't need to look at me. That's great. So thank you so much for being here, and hopefully this will be a useful event for you to put some of the research and evidence and popular topics into context. When we start off with presentations in academic and research settings, we always start with what we call a declaration of interest, which is just a way to understand if the speaker or the person who wrote the book or the paper has any vested interest and might be in a conflict of interest. So I'll start with mine, and then each of the speakers will do theirs as we go through the rounds. So I do research related to vaccines, which is sometimes funded in collaboration with industry, and they would give grants through our institutions. We're always careful that, for example, I don't get paid out of those funds, and also there are careful mechanisms to ensure they do not influence the analysis or interpretation or the writing of the papers, and we would always declare those funding interests in the papers that we publish. So my own declarations have to do with those which are in the vaccine realm. We probably won't talk too much about vaccines, although I also am a member of NACI, the National Advisory Committee on Immunization. So if you hear about the latest vaccine recommendations, I would have been involved in those, and so that's certainly an interest as well. What we wanted to do was talk about the objectives first. So by the end of the session today, hopefully what we'll be able to do is interpret dementia-related research in the news and that you might hear about through social media, friends and family, and think about how we evaluate the credibility of a research story or a source. So really, it helps us to define terms. We're always picky about that too. We like to think about, to make sure that we're all talking about the same thing. So what is research? And we hear the word research getting used a lot to mean a lot of different things. What we talk about in this sort of setting of academics and advancing knowledge is that we want to be creating a body of knowledge on a topic, and to create that knowledge and to further that knowledge. And it's a systematic process, so that's why you might start with studies that show one thing, and then step by step the studies build on one another. So that's also why we don't start at the end with full knowledge of the exact answers that we would have wanted to have from the beginning, right? So the knowledge evolves, and this is why sometimes evidence or our understanding would evolve over time, so it's not so black and white, crystal clear right from the beginning. And it's also why scientists have what might be seen as an annoying habit of never being certain about things. You know, like if you're talking to somebody and they're saying, I know this is the cure for this and that, then that would raise a red flag, right? Because scientists and academics and clinicians who are engaged in these types of research and studies will always be like, but what if? Well, we need to make sure, we need to be subjecting our work to the highest standards of evidence, right? So if you're seeing somebody saying, this is the cure, we can reverse Alzheimer's disease, and this is the easy steps, and by the way, just pay me this money to join my club, then those could be all red flags. So another part of what research is a method for creating new products, or could be through technology, could be through medications, could be other things like that as well. And it could be services. Health services research is an important part of research as well, and we'll be hearing some topics related to that as we come through the evening. So why does research matter? So really, research helps us understand if what we're doing is right, and in the right direction at least, advancing knowledge, solving problems, informing decision-making. The decisions that are made by health systems and even governments hopefully are informed by research. It can help foster innovation and promote critical thinking, for sure. So there are different types of research questions that we might want to answer using different types of studies. So there are lots of different study designs, and we'll talk a bit about them in a moment. But one type of research question would be trying to figure out cause and effect, which is annoyingly difficult to prove. So this is where some of the careful language comes in. But we would like to know whether a medication improves cognition, for example, or does an antibiotic cure an infection. Another type of research question would be observational, or trying to figure out relationships. So for example, one topic that might be of interest in relation to cognition and dementia would be, what's the relationship between wildfire, smoke exposure, and dementia and cognition? So that is something you wouldn't be able to test by exposing somebody to wildfire smoke. You have to be creative in your study designs there. And then another type of research question would be descriptive. So this is a lot of qualitative work that would say, what are the needs of caregivers for people living with dementia, would be an excellent set of questions to answer using these descriptive studies. And so we do need to understand that not all studies are created equal, they're not all the same. So certainly they have different methods, but they also give us different levels of confidence in the results. So if you hear in the news that a study showed this or that, there's lots of different study methodologies, and some of them are more trustworthy than others. So often this is presented as a pyramid. And it's not to say that the studies toward the bottom of that pyramid are not valuable at all to do. It's just that we have to interpret them in the context of the types of studies that they are. Another thing to be aware of is the way that science works. So researchers would work in teams. Another red flag would be if it's a single person doing an entire study all by themselves. It'd be unusual to see that in health-related fields. You might see that in like philosophy or social sciences, but in the disciplines of health and talking about dementia care and treatments, you would expect to see a number of authors collaborating together on most studies. And then they would write a paper, usually like a document, submitted to a journal, and then the journal has editors, and also the journal has peer reviewers who are volunteer scientists from all around the world who agree to read through the paper, provide their comments and feedback to the authors. So those peer reviewers are a critical step to make sure that the science methods are sound, that the conclusions make sense when considered in context of the evidence that's presented, and that people are not overstating their findings. And so then the authors would get those back to revise their paper and do another analysis or whatever else is suggested. And then eventually it may be accepted at that journal, or it might not be, in which case they'd have to go back to the drawing board and submit it to a different journal. Another tricky thing when it comes to interpreting research evidence is that not all journals are created equal. So there are some journals that unfortunately work on sort of a business model where they would just take money from anybody who submits a paper and submit it to very minimal review, and they're in it for the money, essentially. They call those predatory journals. And unfortunately, some research students and trainees and researchers can get caught up in those, with well-intentioned research and good research, they can get caught up in those journals. But they're also a place where people who are trying to slide things in to the evidence base with perhaps less attention to the details of how they've done their studies, they might submit there as well. And then they end up with a paper that looks just like any other journal article, online especially. And so people, if you're not aware of what journals are good journals and what journals are predatory journals, we might put too much stock in the results that are presented in these predatory ones. So anyway, there is this hierarchy of evidence as well. So we start with like anecdotes and stories and case reports of single patients or people's experiences are interesting and important to hear, but they don't have the weight of evidence that a larger study, for example, some studies that are looking at associations would follow a large group of people over time. And those are cohort studies or associational studies. Like an example of that would be the Canadian Longitudinal Study on Aging. A lot of people here in this area are participants in that, which is an excellent study and an excellent thing to be doing to help advance knowledge. Then if we want to get into studies that try to show causation, then randomized controlled trials are seen as the gold standard for that. So that's where you take a number of people who meet certain criteria so that they're all, like, we understand who that population is, and then randomly assign them to different groups, like drug or no drug, or like this diet or that diet, or whatever the intervention is, and follow them for a period of time. And so that helps overcome some of the biases that might be introduced by selecting people to do your study who might be the ones who would respond anyway, better than somebody else. And then at the top of the pyramid, where we have the strongest evidence indicated there is where people actually go and combine, multiple randomized studies or studies of different types, and they're able, using big data analysis methods now, to analyze them and put them all together. And they call those systematic reviews or meta-analysis. And so that allows us to not just rely on a single study, but to understand the body of evidence that exists on a topic. So that's pretty complicated to try to understand, but hopefully that gives you a little bit of a primer. So what is a person to do? When you're going out into the world, you're reading a newspaper story, you heard something on social media or whatever, and it talks about a research study. So how do we understand if it's a good study, not a good study? So there are various different methods that have been proposed for this. One that is kind of interesting is called the CRAP test, okay? And so we'll run through what the CRAP test is and see if you find it helpful. So this was proposed by a professor in California, and I think when I read about it was that she was frustrated that the students in her university courses weren't able to evaluate what was good and what was bad evidence, and so she developed this as a method that has then been widely taught in universities. So the C stands for currency, and that talks, the point there is it timely? And in a field that advances rapidly, you want to make sure you're right up to date. So if it's something like healthcare, COVID vaccines or Alzheimer's drugs, like that field advances very rapidly. So you don't want to be looking at studies that are 10 years old, 15 years old for that, right? So you'd want something that's more up to date. Also, sometimes a study could have been revised or even discredited and withdrawn. So you want to make sure that it hasn't been withdrawn from the literature and not still be basing your thoughts and ideas on that. And some other fields, though, of course, do stay, or it's important to have a historical look back as well. So we think about something that is like the needs of caregivers or quality of life type research. That could well be older studies that are still valuable. But just think about if it's some new treatment or intervention, we want to be pretty cutting edge and recent. So that's the C. So the next is relevance. Does the information in that study actually answer the question, and who's the audience? Is it intended for the public, or is it intended for like certain medical practitioners, or is it even on your topic itself? So that's just to see if it's relevant to your question. The next is A. Oops. There we go. For authority, and that is the source of the information. That's a really important one. So just as we've talked about giving our credentials, we want to make sure that whoever is telling us this great diet advice actually has some training or knowledge in the dietary field, for example. We want to think about who is the publisher, who's the source, and are they affiliated with some university or other accredited organization, like a charitable society that's trustworthy, like the Alzheimer's Society. And also, in some cases, the website can give you some clues too. So if it's easier in the U.S. because .edu is usually a university from the U.S. .gov would be a U.S. government. .org is an organization, and .com might be business related. So those are things that can give us clues as well. Also, if you're reading through it and there's lots of ads popping up constantly, that might be another clue that maybe it's a less reliable source. Okay, the next A is for accuracy, and that refers to the reliability and correctness of the content. So you want to know where it came from. Is it supported by evidence? Like if you get into reading an article, it should have a methods section that describes in detail what they did, because that's a really critical part of the scientific method, so that we can know what someone did and that could be replicated. Has the information been peer reviewed? Like I mentioned before, that usual process. And generally speaking, that would be specified in the information in the small print on the journal article itself. You can also see the timeline from when it was submitted to when it was published, which usually peer review would take at least a number of weeks, and then you have the revision process as well. Is the language unbiased and free of emotion? So this is where you want to be concerned if they're talking about the cure for this, or definitely that, or certainly causes this, would be a less scientific way to present things. And are there typos that would suggest that it's written by some sort of bot or AI or whatever? Which is a whole other layer of problems that we're going to encounter. And then the P is purpose. And that refers to why this information exists. So do the authors have a vested interest? Is it written by some business entity that's trying to sell you something? Is there some link to click to buy supplements or a membership? Or do you have to pay fees? Or there could be political or other ideological biases. So that's where it's important to understand those, and looking at the funders of a study and this declaration of interest again might seem like a small detail, but it's quite an important one when you think about why are they telling me this? Are they trying to gain something from me? All right, so we'll give a couple examples, and these might be ones that you've heard about in the news or otherwise. So one is called the Bredesen Protocol. Has anybody heard about the Bredesen Protocol? Interesting. Okay, so a few. So this is essentially, it's a scientist called Dr. Bredesen who's developed a protocol which is a very specific bunch of dietary supplements using yoga and mindfulness and fasting for certain periods of time every day, and buying a membership to their sort of company and paying fees for assessments along the way and stuff like that. So anyway, the claims of this are laid out in various papers. These are the 3 initial papers, and also in books that you can purchase, of course. And if people have questions, we may talk about them later, but it is something that we're aware that's out there. So essentially, let's look at some of the papers. So the first paper was published by this author, by themselves, for one, and it talks about reversal of cognitive decline and how novel it is. So the language is getting into a little bit too much certainty for what we would generally like to see in a scientific discourse. Also, this journal, Aging, happens to be one of these predatory type journals, or at least many people have in the field think that it's one of the predatory journals that publishes for a fee and doesn't subject to too much peer review. And we can see that, I don't know if we got the circle here. Yeah, so it's small, but anyway, it was accepted and published within a week of being submitted. So again, they didn't have time to submit it to a proper peer review. The second paper, likewise, was in the same journal. It's a case series of 10 patients. They have no methods section at all, so they don't describe in detail how the methods were conducted and how the patients or participants were invited to be part of the study. And they just sort of give a summary of how great all of them did with the methods that they propose. It's in that same journal as well. And then the third one is, again, a case series of 100 patients or participants, again, with no method section and no description of what exactly was done other than join my program and pay me, $70 a month or whatever it is. So that's an example where we would have some concerns about the validity, and we would also be concerned because they're selling this sort of hope and certainty in a way that's not been backed up by evidence. So the next one is the Mediterranean diet. So we can think about that. You probably heard about the Mediterranean diet. Mediterranean diet is well established as a dietary system, for sure, and it has many benefits. And so there are some who would claim that the Mediterranean diet is the way to prevent dementia. So, and that will turn up in the news stories too here. So here's one. The Mediterranean diet may reduce. Now, so that at least is tempered in some ways, right? So it's not saying certainly will. There are a number of studies that have been done, so the big cohort studies, observational studies. Again, it's kind of difficult to randomize people to diets and lifestyle changes that last a long time. But these are some of the headlines that we'll see. So we know that the research is current because it's just from this year. In fact, the authority, the authors are academics from well-known universities, and they don't have competing interests, so they're not trying to sell you their own supplements and diets. The funding has been received from public funders, so like the Medical Research Council, or in Canada, the example would be the CIHR, the Canadian Institutes of Health Research. They describe studies, I'll put a, oops, I messed it up, with a large number of participants. They talk about things like adherence to the diet is associated with lower risk of dementia. So there could be some promise in such research like that, right? But what we'd like to avoid is too much emphasis on this is the answer, this is what you have to do, especially if people are then trying to move beyond that to sell that to people in the community. So in conclusion, this would be promising research, needs more work, and there are some things that we can learn from it. And again, it's a good exercise to run through the sort of 2 examples of the CRAP rules. Alrighty. So going forward, what we're gonna do is engage your CRAP radar whenever you're hearing new studies or reports in the news. Consider the currency, relevance, authority, accuracy, and purpose. You can always look at, if an article or something in social media is like talking about a study, you can always go and look up that study. You can look at, even if you search it on search engine or look Google Scholar, usually you'll find the article or at least the summary of the article. You can search for other reputable sources to see if other sorts of studies have been replicating it, or if it seems to be something that only the one group is doing with self-citations. And if you're not sure, you can call the Alzheimer Society and talk to the InfoLine people, because they'll be able to help you weed through the evidence and understand what reputable sources are. Along the lines of what is a reputable source, the Alzheimer Society of Nova Scotia and of Canada are great sources and have lots of links on their websites, and have actually been in the business of research themselves. They've just last week released the landmark report, the 2nd volume of that, which talks about the diversity of the experiences of dementia in all the provinces in Canada, including Nova Scotia. So this talks about predicting a sharp increase in the number of people living with dementia in Nova Scotia, particularly from equity-deserving communities, so people from racialized minorities. And specifically what they've looked at in this report is people of Asian descent, Indigenous peoples, and people of African descent, and really speaks to the importance of the social structures, history of colonialism, history of racism, and socioeconomic influences that are so important when it comes to determining people's health or influencing people's health. So this is done in a way to engender respect and to try to understand how to best serve these communities and our dementia services going forward. So I'd encourage anybody who's interested to look on the Alzheimer Society website about this new report on the many faces of dementia in Canada. So with that, we are moving into the main event of our evening. This is the hype and the hope in dementia research. So we wanted to get on the same page about research, what research is and what it isn't, so hopefully that helps set the stage a bit. And so next we are going to move to invite our guests to the stage. So I'm gonna wish that my microphone wasn't so loud. Okay, so I wanted to, oh yeah, here they come, celebrities, excellent. So what we want to do is elaborate on what we mean by hype. Okay, so hype is a loaded word. It's maybe why a lot of you are here. So in the context of today's discussion on dementia care, the topics that our panelists have selected are ones that you might have heard about in the media on the news, social media, or from friends. And with our expertise, our panelists are here to help us see a fuller picture of the research and evidence behind the headlines. So let's meet our panelists. From your left to right, we have Dr. Sultan Darvesh, who is a neurologist and the director of the Maritime Brain Tissue Bank at Dalhousie University. And we have Dr. Shanna Trenaman, who's an assistant professor in the College of Pharmacy, also at Dalhousie. Dr. Elaine Moody is an assistant professor at the School of Nursing at Dalhousie. Dr. Janice Keefe is a gerontologist and the director of the Nova Scotia Centre on Aging at the Mount St. Vincent University. And Dr. Katie Aubrecht is a sociologist and director of the Spatializing Care Lab at St.FX University. So, before they speak, we'll ask them to share any relevant disclosures or competing interests, as is always good practice, that could influence their contributions this evening. So, take it away, Dr. Darvesh.
That's great. Thank you very much. I want to thank the organizers for this invitation. I'm a cognitive neurologist. I see patients with dementia in my clinic. I'm also a neuroscientist. I do research in Alzheimer's disease and dementia. I don't have any conflict, but it's important for me to declare who funds my research. And I hold the research chair, the Irene McDonald Sobey Chair for Curative Approaches to Alzheimer's Disease. And I also get funds through philanthropy, Derland Family and Pickett Family. And majority of my research is funded through Canadian Institute of Health Research. Am I supposed to say more?
You can go into your hype now.
Okay, I'm supposed to say more. Yeah. Okay, so I've been asked to talk about the hype with respect to biomarkers. And biomarkers means a biological marker of something. So if you go to your doctor, they will do a test for cholesterol, for example. And that's a good example that, if you have very high cholesterol, then that's a marker for risk for vascular disease and all that. And people have figured out what is the normal range, right? So if you are below this value, then you're okay, sort of. If you are above a certain value, then you are at risk. And that value has been determined by looking at a lot of samples, people, following people. So in Alzheimer's disease, it's the same thing. Right? We all want to have a biological marker that says you have Alzheimer's disease. And we want that, right? And so what clever people, there have been significant progress that has been made. So Alzheimer, when he described Alzheimer's disease, there was this abnormalities in the brain that we now know that these abnormalities are abnormal proteins like plaques, the amyloid plaques, and tau. These are abnormal proteins. Whether they cause Alzheimer's disease or not, we don't know. And the other conundrum about the plaques and tangles is that about 20% to 30% of cognitively normal people have these in the brain. Read the Nun study. The Nun study. They had Sister Martha, who was absolutely sharp as a tack at 95. And there was Sister Agnes, who had advanced stages of Alzheimer's disease. And just go Google Nun study. It'll open everybody's eyes, right? And here is Sister Martha, who was sharp as a tack, and Sister Agnes, who was terminal stages. And when they looked at their brains, they looked the same, full of plaques and tangles. How does that work? Right? So now people have developed these tests. They can do a scan in the brain. They say, oh, you got amyloid. That's Alzheimer's disease. Not true. It is necessary, but it's not sufficient. And it's the same thing with tau, right? So you could argue, well, maybe it's there because it's a prodromal and maybe someday you'll get that, Alzheimer's disease. Well, try to tell Sister Martha at 95, you may get Alzheimer's disease. She's going to tell you to go somewhere else. Right? Or maybe Sister Martha might use some colorful language, but that's okay. The issue is we have to be nuanced, right? So, there's a paper that just came out, right? In CNN, everywhere it was there, right? In media. that you can now do a blood test that says, oh, you got this tau in your blood. You got Alzheimer's disease. Well, you got to be careful because that may not be so. Right? So if you want to know that there's tau in your blood, and then you're going to worry for the next 50 years whether you're going to get Alzheimer's disease, well, what's good of that, right? So there is technological advancement. There is no question. You know, people, very clever people have said, oh, there's amyloid in the brain that may be doing something. True. And they have developed these molecules that they've tagged with fluorine and all that. You know, you inject it and you do a scan. You do a PET scan and there's amyloid. And you say, oh, that's Alzheimer's disease. You have to ask, but I'm not cognitively impaired. So I think it has to be done with very carefully. What we hear in the news media and what we read. These are reputable journals, right? They publish that paper, but they have got their own agenda, right? Because it was funded by the company that sells the kit to do the test. See what I'm saying? That's all I'm going to say for now.
Great. Thank you very much. Always an engaging speaker, for sure. Next is Dr. Trenaman, talking about MABs.
All right, so I'll start off the same way in saying that I don't have any conflicts to declare. However, I'm a pharmacist, and I do research looking at medications and deprescribing and dementia and that sort of stuff. So that's, I guess, the lens that I'm coming at this with. And I'm glad that Dr. Darvesh mentioned that people who have dementia have been shown to have amyloid and tau in the brains, because that's where these MAB drugs are targeted to work. So the one that I'm thinking about the most right now, that's perhaps in the Canadian media the most, is called lecanemab. So that's a biologic drug. And it is currently under review by Health Canada. So you can go onto Health Canada's website and you can look to see which drugs are being reviewed by Health Canada. And that one is there right now under review. And it's being under review for the treatment of Alzheimer's disease. So dementia is an umbrella term that refers to a lot of different potential syndromes whereby people have cognitive impairment and functional impairment, but lecanemab in particular is being assessed for its efficacy in treating Alzheimer's disease. And lecanemab is not the first drug from its class to be around. There are others. So in the United States, the FDA approved a similar drug, which is called aducanumab on June 7th of 2021. And if you followed that story, there's quite a bit of controversy about that. I'm happy to talk with you about that after the event, if you're curious. And the US FDA actually approved lecanemab on July 6th of 2023, so very recently. And there's a third drug coming that's called donanemab. That's not yet approved. I don't know if it's under review by the FDA yet or not, but it's not under review by Health Canada, but it is coming. So these three drugs are similar in their mechanism of action, is that their purpose is to go into the brain and to bind to amyloid and dissolve it essentially and take it out of the brain. The two drugs, donanemab and aducanumab, are both designed to bind to amyloid that's in bigger clumps in the brain, whereby lecanemab is designed to bind to the amyloid when it's in smaller pieces. So very small difference in how the drugs work, because they're both binding the same protein and trying to remove it, but just a slight difference, which you may see in the media as an explanation as to why those two drugs have potentially different effects. There is a lot of excitement about these treatments, and perhaps it's fair to have a bit of hype. These are the first drugs to be approved or considered for the treatment of Alzheimer's disease in like over a decade, so that is big news. But the benefits of these treatments, I don't think, have been well communicated, and I'd like to share my perspective on the benefits and risks associated with these drugs. For aducanumab, when the drug was studied, they were doing 2 randomized control trials. So people were being exposed to drug or a placebo. And as the data rolled in, it showed that there was no benefit of the treatment whatsoever, so the study was halted. That said, there were still people out there who had data that was at the different centers, and as that data rolled in, the drug company continued to evaluate that data because, well, why not? It was there. And one of the 2 randomized controlled trials did show a statistically significant outcome, and it showed that there was a difference between the placebo group and the treatment group in a score of 0.4 on a scale called the CDR-SB over 78 weeks. People who have tried to discuss like what would be a really meaningful difference in that score suggest that somewhere between 0.5 and 1 is a clinically meaningful benefit. So I think I leave it to you, but 0.4 doesn't pass my test of being a clinically beneficial change. Lecanemab is a newer drug, and the results of its studies are not easily accessible and have not yet been published in an easily accessible peer-reviewed way to date. However, in that study, the change in the CDR-SB was 0.45. Again, not meeting that threshold of at least a 0.5 change. So the benefits are there. Maybe they are statistically significant, meaning there is a difference, but maybe it's not clinically meaningful. The concern comes from the risks. And the risks associated with these treatment is something called ARIA, which sounds like it should be a song, but in reality, ARIA stands for amyloid-related imaging abnormality, and it can come in 2 varieties, an H or an E. H standing for hemorrhage and E for edema. So essentially what we know is that people who have these treatments have an increased risk of having either small bleeding or swelling in the brain. And for someone who's already living with cognitive impairment, I find it challenging to think that that's a good thing. We don't necessarily understand what ARIA really is entirely or what its long-term effects are, but what I can say is that estimates from the study suggest that the risk of ARIA for every 3 people treated with aducanumab, 1 person would experience ARIA, which I think, ARIA E, so edema, which is a fairly significant risk rate, right? Treat 3 people to make sure that one of them ends up with that outcome. It's kind of concerning. So benefits, risks always have to be weighed for these treatments, and I think to date, the evidence does not suggest that there are substantial benefits and that there are also substantial risks.
Thank you, Dr. Trenaman. That is a hot topic for sure, and you'll see people entreating you to write to Health Canada to approve it post-haste, so you might want to think about those messages. So next is Dr. Moody, who will be talking about aromatherapy.
Yes, aromatherapy. So I don't have any conflicts to declare. I'm paid by Dalhousie. I have a research program funded by organizations like CIHR and the Alzheimer's Society. So I think, going to change the tone a little bit at this point, going from more biomedical perspectives to maybe bridging a little bit to the social aspects coming up with Katie and Janice. So my background is nursing. I'm a registered nurse, and I have research training. So I like to think I understand some of these more complex research studies, but I'm more focused on individuals and their particular circumstances. So understanding how really big research studies would apply to individuals in particular contexts. So that's the lens that I'm bringing. So I'm going to talk a little bit about aromatherapy. And this came from a news article that was published recently that was reporting on a research study. So the title of the article in the media was, "Can using aromatherapy oils every night help improve memory?" So looking at it in more depth, it was based on one study. Participants were exposed to fragrant oils. So for example, things like lavender and orange, lemon balm, etc. And really, I looked up the primary study, which I think you can all do. Although I will kind of give a caveat, not all research is available to the public. Sometimes you do have to have subscription and our universities have subscriptions, but you might not be able to access them online. But I did look at this one, and it was a study that went over 6 months, and it's the researchers examined olfactory enrichment, and that was the participants were exposed to different aromatherapies, 7 different ones for 2 hours a night for 6 months. And they wanted to see how aromatherapy affected cognitive ability in people aged 60 to 85 with no previous cognitive impairment and who are healthy. The study was funded by Procter & Gamble, so it did have a private company who was providing funding. They tested several different outcomes, so they had different measures of cognitive ability. I think there was like 12 to 14. And they did find that one of those measures, there was a significant change over time. So while the study did have a significant finding, I think that it was probably something that happens quite commonly in the media is they find a research study where there is a significant finding, they pull out that significant finding, maybe try to make a news story out of it and blow it up more than it really is due. And I think that's what happened in the case of this study. It was quite a small, it was significant, so technically they're not incorrect, but the study had a really small sample size, only 20 people in the intervention group, which is incredibly small and really difficult to draw conclusions from. And there was several insignificant or unable to prove significance for several other measures. So not a particularly exciting study from my perspective. While it is technically, significant finding and probably does suggest that we need to look at aromatherapy in more depth, it was not a particularly significant or large significant finding. So more broadly, aromatherapy, Melissa talked a little bit about the different levels of evidence and how you can have all these individual studies, then people do reviews where they put together several studies and do a meta-analysis. So I looked up whether there was a meta-analysis about aromatherapy and dementia, and indeed there was. And the review looked at several, I think it was 13 studies that tested aromatherapy related to dementia. Some found significant results and some didn't. So the body of knowledge, the body of evidence is inconclusive. There's really not good evidence to support the use of aromatherapy at this point. Aromatherapy is, I would suggest, probably less of a risk. In these studies, they're also not doing a good job of collecting evidence about the risks of using aromatherapy and safety. I'd suggest they're probably a little bit less than some of the things that Shanna's talking about, but we really don't know the adverse effects or safety effects of aromatherapy as well. Also, because I'm a nurse, I think it's important to kind of look at the wider context that people are situated in, and particularly around social movements related to wellness and the wellness industry. So kind of assumptions about natural products being more gentle or having less negative effects, less adverse effects, and might be easy to use with few risks. So that is kind of underlying a lot of, I would say, media attention. So I wouldn't necessarily agree with that. I think that some natural products can have significant adverse effects. They can interact with other medications, and they can, they're not as regulated as medications. So there can be impurities or toxins included in those medications as well, or those natural products. So I'd be cautious using them. I know Melissa talked a little bit about some ways to the CRAP method for looking at research studies, and that's wonderful. I was just going to add another point that, everyone's going to make their own decisions about what, people are taking into their bodies. People might have a social circle where wellness products or natural products are really being strongly promoted for various reasons. There's also a lot of businesses, a lot of financial reasons that wellness products are being promoted. So there might be social pressures to use different wellness products. So I would suggest just asking for the opinion of a healthcare provider, someone with some authority, to get their perspective and to balance that with the opinions and perspectives of other people. So registered nurses, physicians, pharmacists, community pharmacists are wonderful for answering questions about medications and also natural products, I would say. But asking opinions for a balanced perspective.
Great. Thank you, Dr. Moody. Some great insights there. Next, we move to Dr. Keefe, talking about the long-term care waitlist, which is a very hot topic.
Great. Thank you so much, Melissa. So now for something a little different. So my name's Janice Keefe. I don't have any conflicts to disclose, although I do have a little advertisement that a recent report by the Royal Society of Canada was released this morning on the state of long-term care in Canada. It's called Repair and Recovery, and I'm one of the co-authors, so I'm a big fan of getting that out there. And some of you will find it's taking long-term care into a human rights perspective as to why we're not treating our older people in that fashion, that they do have human rights as well, even if they're residents of long-term care. So that's what it's about. I'm going to talk about wait lists. I do research in long-term care. I do some work in home care, and one of my passions in the area of research is family and friend caregivers. So happy to talk anything about that. I'm going to talk a little bit specifically to Nova Scotia. We know that maybe you don't know, our wait list to get into long-term care has fluctuated enormously, and we wonder why that is. And so there was a whole slew of new openings of long-term care in 2008, 2009, and the wait list just shot up. And then, it was down to around, in October, December 2020, to about 1,300. Now it's back up to 1,871 people on the wait list. What's really important about that is it depends where you live, and you also have to consider how many people, in terms of, and I would never use 65 plus as a benchmark for needing long-term care. I think most of you in the room would know that, that in fact we should be looking at either 75 plus or 85 plus when we start thinking about potential need. And so, one of the things that we have learned, and of course this is going to be a factor related to the pandemic, is when you look at the trends, even though there are 1,840 some people on a wait list, 50% of those people currently are waiting 75 days on average. Only 50%, so don't get me wrong, are waiting 75 days to get into a long-term care facility. In October, December of 2021, it was 212 days. So the average for half of the wait list is going down to get in. So the numbers I know are somewhat confusing, but I do think it's important that we we understand why we have a wait list and what's causing that. And I want to just talk a little bit about some other research that we've done. Now, this is going to go in the crap model because it's old, and so you can throw this out. But I will tell you that my center did a study about a decade ago, and we randomly selected people who were on the wait list, 50% of whom said they weren't ready to go into long-term care, but they were on the wait list. And so we said, why are you on the wait list? Because my doctor told me to. And that was 40% of those individuals. Now, I'm not saying that's not a bad thing, but I do think that sometimes we can't predict those kinds of things. I think when you look at the state of our home care, you have to recognize, even though the government is developing a lot of new beds in our province, we also have to look to other alternatives, supportive housing. In our study, comparing Manitoba and Nova Scotia, people in Nova Scotia receive home care much later, so they need much more care than they do in Manitoba. So we wonder if there's a preventative area that we're missing here. At the same time, we know that consistency of staff is critically important. So all of these things, I think, factor into the wait list and the way in which we need to address that issue for individuals in our society. And I'll stop there.
Thank you, Dr. Keefe. Certainly an important topic. And last in the hype round is Dr. Aubrecht, who will be talking about dementia villages.
Okay, great. Thank you so much. And thank you, Melissa, and thank you, Janice. So my name's Katie, and my pronouns are she and her. I have brown hair, brown eyes. I'm wearing a gray jacket and a wine-colored dress and heels, so I'll try not to trip. For anyone who may be in the audience here tonight, in person or online, who has vision impairment, low vision, or is blind. I'm a health sociologist, and I'm also a disability studies scholar, and I work at St.FX University, that's in Antigonish. As someone who does work in disability studies, I do have a bias, and that's putting the person who's most directly impacted by policy and practice decisions at the center of not only care, but knowledge production. So ensuring that people with lived experiences are part of that knowledge production process. I am funded by the public funders that have been already identified tonight. So the Canadian Institutes of Health Research, the Social Sciences and Humanities Research Council of Canada, because I am a social scientist, as well as local provincial Change Lab Action Research Initiative, which supports community-driven research. So very grateful for that. So my hype is dementia villages, and it seems like kind of a hype that'd be hard to crap on. I don't know. But really, when we're thinking of it in terms of the evidence, there is very, very limited evidence. And so one of the things that I feel kind of hopeful about, and again, I'll kind of wait until we return after the break to go into more detail, is actually that the media is picking up on this. So I saw a story that was just out a month ago in New York saying, there's very little evidence to support these dementia villages. So what is a dementia village? It's a space that adopts a philosophy of care that we can all get on board with, really. It's person-centered care within an environment that's accessible and supports a dignified life, that allows, is set up, so it's a social and physical environment, so that there is safety, but that people can live with dignified risk. When in more institutionalized settings, they can be so risk averse by trying to keep individuals and people, because they're congregate spaces, safe. staff, healthcare workers, and continuing care workers safe. So a dementia village is still a place that's kind of separated from the mainstream community. And it's modeled off of community in some ways, from a kind of consumer perspective anyway. You'd have access to stores, perhaps meaningful work. That might take the form of gardening. So difficult to kind of critique it too much, but the evidence on these specific spaces is very limited. We have our first one in Canada is in Langley, BC, British Columbia. That's 2019. There hasn't been like deep evaluative work, although it is starting, so there's an emerging evidence base. They really started to take off in the Netherlands. In 2009 with the village of Aubrecht. But what makes them so powerful is not only the philosophy. Who would ever argue with a dignified life, especially given, I think, our recognition in the province anywhere where we have some of the highest rates of population aging and disability, that we know that there's stigma. That it's just what they draw on is evidence from person and person-centered and person-directed care that's been happening for decades, and package it in a kind of approach that people really would have to be able to purchase, like have to have funds to support their ability to be in these places. So there is lots of evidence about the different elements that work well, but not a lot of evidence on these specific villages. And so the big problem, I think, with these dementia villages is that there's not very many of them, that it's almost because there is this packaging of everything that's good. We have this utopic, idyllic understanding about where we want to be or where we want our loved ones or close relations to be, that we don't really take the time to explore the various options that we have and to advocate for more options. And so I'll just wrap up the hype, what evidence, that emerging evidence base that does exist. It's small, like the sample sizes, as Elaine had mentioned, with the aromatherapy, 20 to 30 people. The other big thing is that there's a real lack of diversity. So people that are living within these very idyllic spaces tend to appear the same in terms of the demographics and characteristics and access to economic resources. So it's a homogenous group. So there's not equitable access. And then just as a last point where I think we should, not only does it limit our imagination, but these are spaces where you can't have too complex of a condition and live. So once things get too difficult, to be able to maintain that semblance of normalcy and familiarity, you may have to move somewhere else. So we're not addressing those broader issues that might exist within long-term care. Anyway, thank you.
Thank you, Dr. Aubrecht, reminding us that even things that seem like great ideas need to be evaluated and don't always turn out to be great in the end. So that's the end of our hype round. So we're going to dive right into the hope round. And this round of topics is what you'd expect. So what are promising sources of hope in dementia research? So in this round, each of our researchers will tell us about a topic that gives them, and by extension, all of us, hope. So we're going to run in reverse order. Dr. Aubrecht will start.
Okay, great. Thanks, Melissa. So two really promising directions, I think, that are supported by evidence. The first one would be so collaborative care teams, knowledge hubs, and supports for people with complex care needs in community. I think that's a really key one. The second one would be actual material resources to be able to help people maintain life at home, wherever home may be, for as long as possible. So that might take the form of direct funding payments that also have wraparound services including psychosocial supports. So social supports like, home maintenance and meal prep and home care, perhaps access to medical, clinical supports, but also access to those opportunities for meaningful engagement, which we kind of would look to a dementia village to offer. And there are exciting examples. We just completed a review of international knowledge for a CHR-funded project, and it was really exciting to see what they're doing in Australia, where they even have like stepped or tiered kind of approaches to care, where they support people not only in accessing funds and accessing services, which can be big barriers, but also accessing decision-making supports, because cognitive overload, whether you are someone who lives with dementia or just a member of the public, is a very real thing. And so that administrative burden of trying to make sense of what you're supposed to do and where do you go and how do you get what you need and what do you do and how do you interpret it, is something that people are supported through the whole way. The other thing is that community care is essential because most people actually live in communities. So Janice just talked about how there's these huge wait lists for long-term care. We assume that long-term care will just be there, but the reality is something different. And we don't want to spend that 75 days also in hospital waiting to go into long-term care, because a hospital is not a place where people can live. And I think that's one of the issues that we're dealing with in the province right now. So let's make home and community care better by giving people the supports that they need, informational, financial, and otherwise. But let's also improve long-term care so that when people go there, they can live a dignified life. And we recently completed some ethnographic work on the Seniors Adding Life to Years project, which Janice is a nominated principal investigator for. We looked and went into and kind of dwelled in nursing homes across the country just to learn about what were some of the promising practices that they had. And these practices were really, and approaches were really, feasible, doable. We can have good food, meaningful engagement, and a dignified life. And it might even just take the form of a really coordinated approach to working with volunteers from communities. So what does that look like? And then I think the mental health piece is huge. So I talked about how one of the inequities related to dementia villages is that, even though it might be a place where people who don't meet those normative expectations about related to decision making may be able to live well, we can help to support people, I think, at home in their communities if we provide them to access to mental health supports. And so mobile care teams that have dementia-specific expertise, I think, there's a lot of evidence to support that's the way to go. So thank you.
Great, thank you for those hopeful comments. Next, we're moving to Dr. Keefe, talking about lifestyle and risk reduction.
Yeah, thank you so much. I'm going to talk about a article that would be considered a meta-analysis, I would say, from the Lancet. So for those of you that don't know the Lancet, it is the world's highest impact academic journal. And the lead author on this is Jill Livingston from the UK, and there's a host of at least 30 other authors. One from Canada, from Halifax, Ken Rockwood, our star. And so it's a commission that the Lancet did looking at dementia prevention, intervention, and care. And I just found it really interesting. In 2020, I was in PEI, my little village, and I had to present to the local seniors club, and they wanted to know how to prevent dementia. So I went searching, and I found this article, and I thought, well, this really makes sense. I'm not going to do all the science, but I'll talk to them about what are some of the modifiable risk factors, and that's what this article is all about. I'll just start off by saying this is an update, and as Melissa mentioned, some of these things will be ongoing. I suspect there'll be another one in 2024, but in 2017 there were 9 modifiable risk factors. In 2020 they added 3 more, which were alcohol intake, traumatic brain injury, and air pollution. And so, so this is, I think it's really important. They've divided it into our life cycle. So one of the key modifiable risk factors is education. So that's an early life event. And so they talk about, having education, 7% modifiable in terms of the prevention of dementia. Of course, we know the inequities that occur across countries, and so that's one of the ways when they talk about interventions, the really need for public policy around free education for all youth. They also talk about early or midlife risk factors. And those include hearing loss, which was really big in my little community. I could see one spouse turn to the other and say, I told you should get hearing aids. And so I'm like, whoa, I'm causing marital distress here. But it's 8% of the modifiable factors is around hearing, if you can prevent hearing loss. Traumatic brain injury, 3%, hypertension, alcohol and obesity, 1% each. And then there's still hope for later life. And I should have explained, midlife is 45 to 65, and later life is over 65. And that is smoking. You can modify your prevalence if you eliminate smoking. You can modify the risk factor by 5%. Depression, 4%. Social isolation, 4%. Physical inactivity, 2%, air pollution, 2%, and diabetes, 1%. Now these are all, they're really the proportion of reduction in dementia prevalence if that risk factor is completely eliminated. And we know that they may not all be able to be completely eliminated, but I do think it's important to recognize that 40% of the prevalence of dementia can be modified based on these attention to these particular risk factors. So I just thought I'd share that with you because I think that gives us a lot of hope. There's still hope, regardless of our age, to change our lifestyle, to change some of the things that we can have within our reach, and hopefully that will support us to reduce the incidence of dementia in the future. Thank you.
Excellent. Thank you, Dr. Keefe. That is a great paper for anybody who's interested in looking it up, and has a really nice figure that positions all these risk factors in terms of the life course. Super cool.
We weren't allowed to use that PowerPoint,
yeah.
but I would have shown this figure.
Yeah. It's like the curving paths of life. Yes. Okay. So next, Dr. Moody's going to talk about stigma reduction.
Yeah, so stigma reduction. I think a couple other people mention it, Katie definitely. One of the really major exciting things that I've seen change in research is the recognition of the expertise of people with dementia and caregivers of people with dementia about the experience of living with the condition. So I see that in a few ways brought into research. So now it's common, promoted for people, we call them with lived experience, to be involved in research as team members, as research partners on research teams. So to give direction to research priorities, to give input on research design, to help interpret findings, to ensure that they're relevant to people with lived experience. So patient and public engagement is really exciting. And one of the places that I see it is related to dementia stigma. So you're probably familiar with the term stigma, but it's negative societal views about a group of people, quite often due to a health condition. So there are negative views in society about people with dementia, unfortunately, which contributes to isolation at times, even people isolating themselves, contributes to like treatment nihilism, so assumptions about whether treatment is going to be effective or not. Unfortunately, stigma is present in healthcare organizations and among healthcare providers as well. So people with lived experience and caregivers have become more active in being advocates and addressing some of the stigma of dementia. So one example is a project out of BC, the Flipping Stigma Project. You can look it up. There's a wonderful website where a group of people who have lived experience with dementia, so people who have a diagnosis of dementia, came together and developed some tools to support stigma reduction. So on the website, you can see videos where people talk about their experiences of stigma, what it looks like in practice, what they do to counter stigma in the moment, how they're involved in advocacy. They have tools on the website for people with dementia and caregivers. They can take it into, for example, a primary care provider and say, you know, this is what I'm experiencing. Can you think about this? So the tool's wonderful. I recommend looking at it. It's being well received. We're looking at ways to incorporate it in different healthcare settings, so primary healthcare, acute care settings, to help support healthcare providers have a more positive and realistic view of dementia. The reality is, like so many things, dementia is a process. There are many good moments experienced by people with dementia. There is hope. There's lots of resources and supports, and hopefully better resources and supports going forward with the recognition of the condition and the challenges associated with it. So that's my hope.
Great, thank you. There was there's a research process that looks at the experience of people living with lived experience in different conditions and their research priorities, because those aren't always the same as what the academics and researchers decided to study. And the top of the list for people living with dementia was stigma reduction. So it's really an important issue. So thank you for bringing that up today. Next, we have Dr. Trenaman talking about another type of medications, the cholinesterase inhibitors.
Yes, so for a long time, I was uncertain about the benefits of the main drug treatment that we use for Alzheimer's disease. Those are called cholinesterase inhibitors. And even though I was uncertain, I would still recommend that we use them in practice, particularly when people living with dementia were also living with challenging behaviors that didn't respond to, like, you know, non-drug approaches. And also, like, once these drugs were approved and prescribed and used, there was no real incentive to study, like, what exactly their benefits were, because they had demonstrated enough benefit of some sort, you know, that they were on the market, they were being used. Anyway, fast forward many years, Sweden has a dementia registry whereby every single person who lives with dementia in the country has an annual follow-up, and their clinical information is stored in that data set. And it's really great because you get to learn things about how people live with dementia, and they get to understand what's happening in their country. In 2021, a publication from that registry looked at what the long-term effect of cholinesterase inhibitors was in their country. And what they found is that people who were exposed to a cholinesterase inhibitor within 3 months of their diagnosis of dementia were less likely to die and also had a delayed time to when they entered the stage of severe dementia. So they were able to actually, like, push that back in a subgroup of the population that was studied. So this study gave me a lot of hope because it meant that, you know, even though things had been uncertain, we had still been doing the best that we could for people who are living with dementia, you know, the people we care for and the people that we love. So that's what gives me hope.
Thank you so much, Dr. Trenaman. So those are the medications that are available currently in Nova Scotia, so you may know people who are taking those ones too. Okay, and finally, Dr. Darvesh, who's going to talk about the importance of basic research in the brain bank.
So that's great, thank you. So the hype and the hope, they have to be balanced, right? You can't just crap on one and stuff like that. So if you look at how things have evolved, 100 years ago or more, Alzheimer looked at the brain of the patient that he had looked after. And he was in a university hospital where people had developed methods to fix the brains, to preserve the brains, and stain the brains. So he was in that milieu. If he hadn't been there, I don't know what would have happened, right? So he examined the actual human brain, and he said, there are changes here. And that's what we understand as Alzheimer's disease, dementia syndrome, where these abnormal changes happen. At that time, we did not know what brain cells were producing, the neurochemicals, and how brain cells were communicating with each other. And we found out over 70 years, fast forward 70 years, 7-0, where people understood that brain cells communicate with each other with these chemicals, acetylcholine being one of them. And we know that was, that's important in memory, attention, concentration, and all those kind of things, right? And in 1970s, right, Alzheimer described this in 1906. 1970s, people now looked at the brain tissues in a different way, using the new methods by which people were able to stain and examine the brain. And there they saw that these cells, brain cells, that produce this chemical, acetylcholine, was diminished, like it's almost absent, it's dead. And that was the genesis of the development of cholinesterase inhibitor. Cholinesterases are enzymes that break down this chemical. And so by looking at the brain with newly developed technologies, they were able to say, aha, there's the change. Now you're on cholinesterase inhibitors, as we heard, looking at the brain. So, we are not mice, we are people. So we have to look, if you want to do research in human diseases, you have to look at humans. And so I can tell you, about 30 years ago or so, Ken Rockwood and I, we were talking, and, I said, I saw a patient, and they wanted to donate the brain to go to Toronto. What's wrong with us? So that's when we went to Alzheimer's Society, back then. And we said we would like to start a brain bank. So, this may sound like a conflict. It's not conflict, right? We started the brain bank so that we are able to do research using human brain tissues. And so Alzheimer's Society started that, helped us start that, and they are still doing that. So it has been a huge success. So this is a great thing, right? So we don't know what somebody clever out there in the world is going to develop another way to look at the brain, just like clever people looked at the cholinergic system and cholinesterase, And so from my perspective, the hope is to continue to look at human brains. And it has been very successful. We have had 1,500 brains in the last 30 years that we've sent around the world, right? And so my hope is that, there has been huge technological advancements, huge, right? We can do brain scans, we can do tests, and we have machines to do that. But are we looking in the right place, right? If you say amyloid causes this, and you got amyloid, you're going to get, you tell Sister Martha that, you can't do that. You have to be able to look at the brains and the blood tissues and all that kind of stuff with more technologies and in a different way, so that we have a better and more specific and more accurate early diagnosis. Without that, it's going to be a problem, right? So the hope is that through this philanthropy, this is the highest gift people have given us, right? To start the brain bank. And so to me, the hope is that people will continue to do that with technological advancement, to look at the brain tissues in every different new ways that we can, so that we can find a cure for Alzheimer's disease. That's all I'm going to say.
That is certainly a tremendous resource that has been developed over time by Dr. Darvesh and collaborators, and including the Alzheimer's Society. And it's something that the Alzheimer's Society can give you more information on if you're interested in finding out about if somebody in your circle is interested in that eventual gift. And it brings up the point, too, that being a participant in research is a way that you can be engaged in helping create this knowledge over time. And again, the Alzheimer's Society is a great repository of reputable research studies that are ongoing. If you are interested, you can call in and ask, if there are any that are recruiting now. So now we get to the fun part of the audience engagement. So we have a question and answer session that'll be running for the remainder of our time. And to make sure that we have opportunities to ask questions for both the virtual participants online and the in-house participants, we have a unique format. So instead of asking questions out loud into a microphone, we have a virtual polling tool. So if you have a phone or a tablet with you, you can visit the address that's up there on the screens to submit questions. And we also have staff throughout the auditorium here who will put their hands up now. Oh, they have pickleball paddles. Excellent. So if you need help typing in your question, they will do that. So just put your hand up and the pickleballs will come to you. Type away and we'll see where we've gotten so far. All right. So we'll start with one that we thought might be a hot topic. The question is MAID available for people with dementia? And this is a good question. So I would say that yes, in general, MAID is available for people with dementia. There are certain parameters around how that is accessed. So essentially, one has to be able to make the decision around whether they want MAID and explain their rationale and their reasoning for that at the time that they meet with the assessors. So the MAID process is such that you have 2 assessments, and then if the person is deemed eligible, then with dementia, the way that the system works so that it's not yet established so that one can write into a living will or an advance directive to say, in the future, I want MAID. What people can do, though, is if they meet criteria now, they can say, well, I would set a date, I would set it 6 months, a year from now, and that's an agreement with the provider who is saying that the person's eligible. And then when that date rolls around, then you can reevaluate it and say, no, I want to kick it into the future again, another 6 months, a year, and have that process continue. Or if the date has come and the timing is appropriate, then the MAID can be provided at that time. So it's gotten around an official sanction of advance requests in this way of setting a date with an advance kind of agreement. If you do have any questions about that, the MAID program is accessible. You can see them, they have a website online, and also the Alzheimer's Society can take questions too. Another question that we have is about leaky gut and whether leaky gut could be a contributing factor in plaque buildup in the brain. Anybody want to take that one? It's an interesting question around, there is a body of evidence that's being built around the how the whole body is connected and how inflammation can come from things like the microbiome or the bacteria and whatever that are living in one's gut, and that can affect the whole body. So I will say, I suppose, that there's advancing research on dementia talking about the importance of inflammation in brains and how these cascades and processes that happen with the amyloid and other changes can be sped up or started with inflammation. Another type of inflammation that is being investigated is infections, viral infections or other types of infections. And so in fact, one of the hopes that I would suggest is that there is some evidence to suggest that if we get vaccines to prevent things like influenza or shingles, then we may have a lower risk of dementia through some of these mechanisms. So otherwise, there's quite a lot that's still being worked on there. So I don't know that we have any particular specifics on the gut-brain axis. Would you say any additions there?
That is a very important point. And, this has been a significant discovery, to put the relationship between the...
Oh.
Sorry. So the relationship between the brain and the gut, and of course there are billions of different species of microorganisms that grow in our gut, and it has been shown that they actually, when they metabolize things, they produce chemicals that are neurotransmitters. Serotonin, a feel-good neurotransmitter, a lot of it is produced by microbes in our gut. And so it's an important area of research, and I'm sure there's going to be good stuff coming out of that kind of inquiry.
Sounds good. We'll see. Interesting. So there's a couple questions that may be linked about light and sound therapy, and particularly diurnal variation, so day-night variation. And one question is that sundowning is a fairly quite a well-known entity that happens to people, or many people, not everybody, but can happen when people are living with dementia, in which later in the afternoon and into the evening, people may have personality behavior symptoms that could be troubling to them and their loved ones. So then the person is wondering whether sun rising is also an issue. So I guess that's a tricky one, but one thing that I think it relates to the other question as well that was there is around whether light therapy is useful. So that, I guess, would fall into fairly well in the hype, but still toward the hope, maybe. So, there's some evidence that does suggest that dementias can be a chronobiological, or have a chronobiological component, which just means that they relate to the day-night cycles that the body goes through. And certainly that is felt to contribute to this sundowning that would happen as the daylight wanes and it gets darker. And it does suggest that people would benefit from having clear cues about whether it's daytime or nighttime. So like access to a window, looking out the window, getting outside when possible. There are questions about whether people should be doing the SAD light, like those light boxes, for dementia or not. And then that is harder to know for sure. Like the evidence, I would say, is still inconclusive on that. But it is something that could be tried if it's something that's of interest to you and you notice that you or the person that you're thinking about is particularly sensitive to this day-night cycle. Any other comments about that one? Let's see where else we have. Okay, here's another question. Has there been any current research showing a genetic link in families? Where, speaking about, does dementia run in families? Do you want to address that?
Yeah. So we have Alzheimer's disease can run in families. The familial form of Alzheimer's disease is extremely rare, 1% maybe. And this is where we know where the mutations are, at least in some of these conditions, right? And so there, you don't even have to ask the family history, right? It's autosomal dominant familial Alzheimer's disease, very rare, less than 1%. And we have followed maybe very few families because it's so rare. But they may be. Once again, I come back to the research part, right? I mean, these are obvious. These individuals start to develop dementia at age late 20s, right? I mean, that's That, you don't have to ask questions. There it is, and we've seen that, fortunately. So, whether there are other genetic forms, we don't know yet. The research will tell us. There are other things that people know that about other genes. So you may have heard about ApoE4, apolipoprotein. It's a protein that's involved in lipid metabolism, and people have seen association, keyword, association between higher level of one form of ApoE4 in Alzheimer's disease. Remember, association is not causation. So if somebody comes to me and say, could you do ApoE4? Well, what am I going to do with the answer? Because I can't tell you what they will get it. There are other conditions, neurological conditions like Huntington's disease, where if you find the gene, the progeny, you're going to get that, right, at some point. But that's not so with like ApoE4. But the other ones that I'm talking about, the familial, young onset, very rare, there you can predict. But, I think that we need to know a little bit more about other genetic factors. They could be polygenetic or what, we don't know. But that's where we need to look at some research.
Thank you so much. Ongoing research important for sure. Here's a question about how would we replicate Dementia Village practices at community level? And what elements can be drawn upon to implement and maybe evaluate here?
Okay, thank you. That's an excellent question. And 5 minutes goes by so fast that I'm really grateful for the opportunity to speak to this. Like dementia-friendly communities. And there's Alzheimer's Society, Canada, World Health Organization. It's related to age-friendly communities. Like there are many resources out there that adopt that human rights approach also that Janice talked about. And I think we're at a real pivotal moment right now. Sometimes dementia villages are described as a paradigm shift just because there is a recognition of people who live there as people. But we're in a paradigm shift. We're actually kind of fundamentally transforming the ways that we think about disability as a difference. And recognizing that the challenges that people have are not necessarily solely related to a medical condition, although that can play an important role, but often very much informed by the barriers that exist within their communities, whether they're attitudinal, so stigma, but also physical, social. So one of the projects that we're doing with Alzheimer's Society Nova Scotia right now that Change Lab Action Research Initiative has supported is mapping those services and supports that exist and trying to understand how to communicate it in ways that is accessible to people, that they can access it so that they know how to, I think, reimagine and reinterpret their lives as something that you kind of almost have to work at. We're not just going to defer to medicine to tell us who we are. We have to try and figure out when we're experiencing some challenges now, I think, and which makes this hype versus hope all the more important, how we're going to access information, interpret that information, and even know the types of supports that we need to be able to do that. So I think we can, it's very easy, it's all there. I think the issue with the dementia villages is that there's a kind of corporate model. Like that's the issue that we might take issue with, the ways that it gets produced, draws on all this evidence about what's already working. Things are already working. We can kind of look with, I think, dementia-friendly communities initiatives as offering a scaffold and an interpretive lens that we can use to kind of make sense of what's out there. So that would be where I'm at, end of thought.
Excellent, thank you. Oh, here's an easy one for you, Dr. Keefe. So what improvements can be made in the long-term care system in Nova Scotia to better accommodate those experiencing dementia?
Oh my God. 5 minutes, you said? No. Okay. So that's a great question. You know, all 4 of our Atlantic provinces have had expert panels in long-term care. Everyone's trying to understand how to improve the experience. I think the national standards for long-term care, and I know this is, I have to declare my bias because I was on that team that was put out in January of 2023, really put forth this approach that Katie talked about having the person at the center, and it not only being about quality of care, but also about quality of life of the residents, and recognizing that that can't happen unless we have quality of work life of the staff. And so we know right now, like our staff in long-term care are, you know, they're just stretched to the nines. We're doing everything, trying to like put people in to help with the provision of care, but we're not, for whatever reason, we have to start looking more, not just about the recruitment of the workers, but also about their retention and how, you know, how we support them, how we keep them, you know, positive in their place. So, you know, there is no one simple answer. It's so complex. I'm actually chairing the panel in Newfoundland Labrador right now, and it's, yeah, I mean, it's really tough. I guess I would say there's no magic wand, but there has to be some clear structural changes in terms of how we understand quality of life, the value of quality of life, the value of quality of care, which I think is already there, but also that quality of work life for the staff. Because until, like, you know, Katie and I work with Pat Armstrong, and that whole, the quality of work is the quality of care, right? And so we really have to recognize the value of the staff, but at the same time, the I want to say the rights, but the residents of the system they're human beings. We have to realize and treat people with respect and recognize that they also have rights. And I'm a big believer in that. So I'll stop there. I could go on forever.
Excellent words of wisdom. Okay. Here's a question relating to the aromatherapy topic, which is a tricky one. So many people living with dementia may lose their sense of smell. So is their olfactory sense damaged to not be able to smell, but are they still receiving benefits of aromatherapy? Is that something that is mentioned in that literature, as far as you know, Dr. Moody?
Dr. Darvesh to take that one. Yeah, no, I was just saying I'll pass it over to Dr. Darvesh. Oh, I did have a thought, but... Oh, no. So I think, I don't know, because in terms of like losing sense of smell, I guess what I think is important, that what you're breathing in is important to your brain function. And I think that came up in the Livingston report, that pollution can potentially play a role in prevalence of dementia. So yeah, but maybe you can speak more to the areas of the brain that
yeah, I
are
think
affected.
this is important, right? So I check, when I do neurological examination, I check olfaction on everybody.
Maybe put the mic up there.
Thank you.
He checks everybody's sense of smell as
I check
part of his
everybody's
visits.
sense of
Yes.
smell. But there's a difference between losing sense of smell and then having the benefit of some of these chemicals. So I was reading a book about the difference between, say, walking around in the city, right? You take a long half an hour walk in the city versus walking in the woods, right? It's different. And in the woods, there are other aromas that are going on, right? The pinings and all that kind of stuff. And people have shown that some of these aromas, some of these volatiles, have effect on other neurotransmitter systems in the brain. So it's not just the smell, but it is the exposure of these aromatics, they're volatile, I shouldn't say aromatics, these volatiles to other transmitter systems in the brain. So there may be beneficial effect, according to the literature that I read, that goes beyond just the smell, because it exposes the brain to these chemicals that may be beneficial.
So that is an interesting question, and it would be important for the studies to then specify whether they're enrolling people with different senses of smell or whether they limit to only people who could smell.
And also to consider that if you're studying people with cognitive impairment, they may have smell, but not the language to let you know that they have the smell.
Yes. True enough, yep. All right, let's see what else we have here. Can anyone speak to the idea of cognitive reserve to help prevent dementia? Let's talk about cognitive reserve. So cognitive reserve is an idea that has come up actually in a few of these talks. I would say when we talked about Sister Martha, she has good cognitive reserve. She has the changes in the brain, but not the memory problems, right? So what we would like to know is how to emulate that. So one way to do that is through some of the lifestyle interventions that Dr. Keefe was talking about. You know, the best studied ones would be exercise, social interaction, and brain stimulating, engaging activities like keeping up with the news, socializing, reading, whatever you enjoy. So those types of things do contribute to cognitive reserve. I suppose another thing that might be the opposite is taking medications that are specific hits to one's brain, and perhaps Dr. Trenaman wants to talk about that.
So there's, I would say, like, not necessarily recent, but there is a body of literature that's growing that shows that a particular type of medication called anticholinergic medication can actually affect your ability to have cognitive function. So the best example of this was in the ADNI data set, which is the Alzheimer's Disease Neuroimaging Initiative, where they took a bunch of people who were cognitively normal, and they took a bunch of people who had mild cognitive impairment, so did not meet the criteria for having dementia, but definitely had changes in their cognition, and they looked to see how their brains were functioning, and they had like markers of how they measure it, and they show that cognitively normal people are here, and the people living with mild cognitive impairment are here, so just a little bit less, and then they looked to see if those people, a different group of people with the same sort of cognitively normal or mild cognitive impairment, how their cognitive function was when they were exposed to anticholinergic medications, so people that were taking those medications, and it showed that cognitively normal people who exposed to anticholinergic medications had slightly less cognitive function than those people who were not exposed, but not a statistically significant difference. Just a tiny little difference if you look at the graph. And for those people with mild cognitive impairment exposed to anticholinergic medications, they had a substantially, like a statistically significant reduction in their cognition. So it seemed like people who are cognitively normal and are exposed to anticholinergic medications, maybe it affects them a little bit, but people who are living already with mild cognitive impairment and are exposed to these medications have even more impairment. So anticholinergic medications are drugs that block acetylcholine. That's that chemical we were talking about. It's the opposite sort of like cholinesterase inhibitors. And what we know is like a lot of those medications are common out there. Things like dimenhydrinate or diphenhydramine can be anticholinergic. Many medications that are active in the brain, so think about things that are like antidepressants, can be anticholinergic. It's a vast group of drugs, and we don't really understand if one anticholinergic drug is as bad as all the others. Suffice to say that if you don't need those medications, it's good to avoid them. In fact, you should avoid whatever medications you don't need. I advocate strongly for deprescribing in any way. So, yeah.
Even if they're available over the counter. And so
yes.
she's
even if
a
they're available
pharmacist.
in gas stations, not good.
Yes.
Not always
so
good.
she's a pharmacist, so she'll never use brand names. But just so you know, like these are like the Benadryl, the Gravol, the muscle relaxants, sleeping pills, stuff like that. Yep. All right, so we're getting toward the end. And there's a question about whether advances in machine learning will contribute to the field, particularly around research at the brain bank. Interesting, eh? So it's about like pattern recognition, picking up changes.
You know, this machine learning and artificial intelligence, it's coming, but it's scary because something that we don't understand is scary. And I think that once we start to understand it better, it's going to be helpful. But you know, for example, I take you back 100 years, you know, when radioactivity was discovered. You know, people were, you know, all of a sudden, there was something going on out there, you know, but it was scary for people, and they didn't use it properly, right? And then we tamed it. It's going to be the same way, I think, with artificial intelligence. And to me, artificial intelligence is an oxymoron, right? Like, how can intelligence be artificial, right? And what is intelligence? Do we know what intelligence means? I'm not quite sure. You know, people do cognitive testing and say, your IQ is that. What does that mean? You know, so a machine, a computer, right? You have somebody showing you that it's going to snow tomorrow, right? And they show snow, right? Is it snowing in the computer? No, it's snowing outside, right? And so, you know, I think we have to reconcile what we mean by artificial intelligence. I think the concept of intelligence is probably a fallacy, right? But that's philosophy.
There is some deep philosophy, which we'd love to have time to get into. I mean, this machine, there are different elements of artificial intelligence too, and machine learning is some very powerful analytical techniques that is being used in studies now, especially these really big studies of like the registries of the population level where you have hundreds of thousands of people's health records that can then go into very rigorous models to help understand patterns and look for associations to guide research into the future. So that, I would qualify that as hope. So that's a great point. So I think we're come to the end of our question and answer period. Thank you so much for your engagement and all the great questions. I will, for any questions that we didn't have a chance to address, do feel free to call the confidential helpline, info line of the Alzheimer's Society, which they'll probably pop up on the slide there, and get one-on-one counseling and advice. And they'll hook you up with good resources. So with that, I'll pass the mic over to Sasha for the conclusion.
Thank you, Dr. Andrew. Wow, we covered a lot of ground this evening. We hope you all enjoyed this polling tool that we used tonight. A few round of applause. Thank you for giving it a try with us. We're grateful we could hear from so many of you in the room and online. I also want to acknowledge the expertise and, let's be honest, bravery of our experts this evening, engaging in this dynamic public dialogue on such a wide range of research topic. So a thank you to Drs. Aubrecht, Dr. Keefe, Moody, Trenaman, and Darvesh for sharing your expertise this evening in such an approachable way. And of course, to Dr. Melissa Andrew for guiding our discussion. No small feat given the topics we had. So as our event draws to a close, I would like to say events like this come together with the support of many helping hands. I'd like to give a heartfelt thanks to the staff behind the scenes at the Alzheimer's Society of Nova Scotia, ensuring all our logistics were in order and providing hands-on support tonight, even with pickleball paddles. I'd like to say hats off to our tech support, Basil AV, as well as a hospitable team here at the Halifax Central Library. And while we have you, we'd like to take a moment to mention some exciting events on the horizon. We'd love for you to save the date for this year's IG Wealth Management Walk for Alzheimer's, happening on Sunday, May 26th in your communities across the province. You can visit walkns.ca to learn more and register your team, and it's such a brilliant show of community support. We hope to see you. I also wanted to mention we have, and you've heard this evening about dementia-friendly communities. Thank you for nodding to them, Dr. Aubrecht. For the very first time, we're delighted to be presenting Dementia-Friendly Community Awards in June of this year. And the hope is to highlight great work that's happening in our communities across Nova Scotia to create welcoming and inclusive spaces for people living with dementia and their care partners. So we've chosen 4 awards that we'll be recognizing this year: Dementia-Friendly Voice, Ally, Group, and Organization. So to make a nomination, you can see the website here, and to find out more, please take a peek, and we're really looking forward to our inaugural awards this June. But wait, there's more. Each year, we're also pleased to recognize students pursuing dementia research by offering our Student Research Awards. They're actually selected by many of the experts here tonight. That's how you know they're reputable. 3 awards are available. We have 1 graduate level, postdoctorate level 1, the Phyllis Horton Award, and 2 undergraduate level awards, relatively new to us, called the Abe Leventhal Awards. The call for applications is now open with submissions due April 15th. So if you know any students in Nova Scotian institutions, please encourage them to pursue research in dementia. And last, but certainly not least, I want to thank each of you for joining us on this cold January evening. It is so clear there's an appetite for more discussions on dementia research. It was our privilege to explore these hype and hope topics with you this evening, and thank you for your engagement in our Q&A. We hope you have found a new resource, made a new connection, or have a new outlook on research in dementia. And this is one big final favor of you before you pack up. Please be sure to take a moment to give us some feedback on tonight's program, either online or the paper form, the green form in your hand as you entered. Your insights are so valuable as we plan future events. Be safe, take care, and we look forward to seeing you again. Thank you.